Hi, my name is Rami Sweis. I'm a gastroenterology consultant at University College London Hospital. First, I'd like to thank the ESNM for inviting me to speak today on hypercontractility and spasm as an update to the Chicago classification version 4.0. I'd also like to offer special thanks to Yinglian and Mark Fox for their contributions. The Chicago classification 4.0 divides esophageal and lower esophageal sphincter disorders into disorders of the esophageal junction and disorders of peristalsis within the esophageal body. Today, I'm going to discuss hypercontractility and diffuse esophageal spasm. With regards to hypercontractility, the parameter of interest is the distal contractile integral. We no longer use amplitude alone as a measure of hypercontraction. Rather, we use three parameters of the length of the esophageal smooth body, the time of peristalsis, and the average amplitude within to define the contractile vigor, also known as the distal contractile integral. In so doing, we can now define normal as being a distal contractile integral between 450 and 8,000, absent or failed peristalsis as having a DCI of less than 100, hypotensive as being a DCI of between 100 and 450, and hypercontractile as a DCI of greater than 8,000. The failed and hypotensive contractions are described as being ineffective, while the rest are effective. This definition of hypercontraction has progressed through the different versions of the Chicago classification. The first iteration described the nutcracker esophagus, whereby the DCI was between 5,000 and 8,000, and spastic nutcracker as being over 8,000. The second iteration described jackhammer esophagus as being hypercontractile with just one DCI of over 8,000. And the third required at least two DCI measurements of over 8,000, with which may or may not include the lower esophageal sphincter. These are all based on single water swallows. The current definition again requires a DCI of over 8,000, and it should be not associated with any mechanical or functional obstruction. This can include the lower esophageal sphincter, as you can see here on the right, or it might not include the lower esophageal sphincter and only include the esophageal body. This can be single-peaked or multi-peaked or jackhammer esophagus. It is this multi-peaked jackhammer esophagus that is typically associated with the highest DCI values and the most symptoms. Comparisons between hypercontractility, including the lower esophageal sphincter, and not including the lower esophageal sphincter, showed that there's very little difference in terms of demographics, esophageal findings, symptoms, etc. And so it was determined that these could be put together as one disorder. In fact, hypercontraction with a DCI of over 8,000 is very rare. This was found in only 3% of patients with symptoms. We should also define what is clinically relevant and what is conclusive. Conclusive manometric diagnoses require at least two hypercontractile swallows, while clinically relevant subjects should have symptoms of dysphagia, non-cardiac chest pain, or otherwise. Indeed, this study looking at 34 patients found that dysphagia, chest pain, and heartburn were the most likely symptoms to present in patients with hypercontractility. And in this study, looking at 221 patients, dysphagia was the most common symptom, followed by heartburn and chest pain. With regards to spasm, distal latency is a parameter of interest. This measures the time to deglutition, the time from initiation of swallow to the end of peristalsis, where the velocity of peristalsis changes from the esophageal body to the LES after contraction. We require a minimum amount of time to allow for propagation. and this is considered to be 4.5 seconds. Since the first iteration of the Chicago classification, we have changed from using velocity or contractile front velocity as a measure of spasm to using distal latency or the time to deglutition. The second iteration required at least two of those premature contractions with a distal latency of less than 4.5 seconds. The third iteration required this to also include a DCI of over 450 millimeters of mercury seconds centimeters in order to confirm that there is peristalsis. We no longer use velocity. That's because the rapid contractions were more commonly associated with hypotensive motility, dysmotility, and impaired bolus transit was often due to proximal bolus escape, while in premature contractions and spasms defined with distal latency, impaired bolus transit is commonly due to bolus entrapment within the esophageal body. And it was determined that this was a better measure. So diffuse esophageal spasm is described as a distal latency of less than 4.5 seconds with a distal contractile integral of over 50 millimeters of mercury seconds centimeters. And now, if we have a short distal latency and obstruction, this is described as type 3 achalasia. Without obstruction, it is diffuse esophageal spasm. Again, we need to define what is conclusive and clinically relevant. Conclusive, the distal esophageal spasm requires at least 2 out of 10 water swallows or over 20% of premature contractions within the swallow protocol. And clinically relevant symptoms are required, such as dysphagia and chest pain, as you saw with hypercontraction. It's important also to define who is taking opiates, because opiates can mimic any form of hypercontractility or spasm. We also need to exclude obstruction. Ultimately, obstruction can lead to any form of hypercontraction or spasm as a consequence of the esophagus trying to overcome the obstruction. So it is crucial that we exclude a non-relaxing lower esophageal sphincter before we define patients as having hypercontraction or spasm. Here is a patient with normal water swallows. Then suddenly there are segmental simultaneous contractions. For all intensive purposes, this is diffuse esophageal spasm with a distal latency that's short. However, the patient had no symptoms and was looking at me comfortably. So what happens if the patient has no symptoms, but there is clear pathology on manometry? This is where we should be including provocative testing. Provocative testing tries to replicate normal eating and drinking behavior by changing the position of the patient, by allowing them to drink larger volumes of water, eating solids, either single solids or a meal, or observing them in the postprandial period. By changing position, we can exclude artifact and identify peristaltic reserve. By increasing the volume of fluids, either with multiple rapid swallow or free drinking, we can assess for deglutative inhibition, assess for esophageal junction outflow obstruction. And by adding solid swallows, we increase the sensitivity to identifying symptoms. Mark Fox and his group have defined the parameters required for measuring and identifying pathology whilst eating. So these techniques are now established and normal values are present. In so doing, studying 750 patients with symptoms with both water swallows and a test meal found that a meal more than doubled the diagnostic yield of a major motor disorder. Indeed, spasm and jackhammer esophagus more than doubled when providing a meal compared to water swallows. Also crucially, when water swallows were given, only 1% of patients had symptoms, while when solids were provided, 2/3 of patients had symptoms reproduced. It's important also that we use provocative testing to unearth and identify pathology which otherwise would not have been seen with single water swallows. And we can see this again and again, whereby hypercontraction can be produced with solids but not with water. Similarly, spasm events can be reproduced with solids and not with water. How do we treat these patients? Commonly, treatment is conservative. Patients often tend to respond spontaneously over time. And if they require therapy, often we advise for dietary management with eating soft foods, having a sip of water after a few swallows, avoiding culprits such as caffeine, and avoiding also things like stress. Acid-reducing medications can also help, especially if there are symptoms suggestive of heartburn, as there seems to be an association. Treatments also can include medication, such as calcium channel blockers, nitrates, phosphodiesterase inhibitors, such as sildenafil, can enhance endogenous nitric oxide. Tricyclic antidepressants and SSRIs can reduce visceral sensitivity and also have an impact on coexisting anxiety, which is present in many of these patients. Botox can be used, and it has been shown since the mid-90s that Botox can reduce symptoms of chest pain and dysphagia. In a randomized controlled trial in 2013, Botox compared to placebo, there was a clear improvement in patients having Botox compared to sham, primarily in those who have dysphagia. So it is suggested that Botox should be primarily used in these cases where dysphagia is a primary problem. The ESGE guidelines have also been published recently, and they suggest that irreversible invasive therapies such as POEM should be avoided unless absolutely necessary. This is because there are no comparative studies that address the treatment of hypercontractions and spastic disorders with POEM, and the blinding is not possible. The series that are studied are small, with short-term studies. They're mostly subjective, and there are considerable publication bias. So it's not clear whether POEM is justified in this context. In conclusion, we need to establish what is clinically relevant versus an incidental finding on manometry. And this is done by defining who has typical symptoms at the start. And I would also put it to you that we should try to reproduce symptoms at the time of the test to define what is clinically relevant. And that is done by provocative testing. We should confirm that there is no obstruction. And we can do this with water swallows as well as with provocative testing because it is imperative and will change management. And we should confirm that there are no opiates being consumed. Provocative testing can unearth or confirm pathology. It can reconfirm that there is no obstruction, and we should use this to reproduce symptoms. Treatment is often conservative or with medical therapy, and we should try to avoid irreversible and invasive treatment such as POEM. Thank you.
Hi, my name is Rami Sweis. I'm a gastroenterology consultant at University College London Hospital. I would like to thank the organising committee of the ESNM for inviting me to speak on ineffective esophageal motility and aperistalsis as an update to the Chicago Classification 4.0.
The classification of motor disorders published in 2015 divided this motility into major motor disorders and minor motor disorders. Absent peristalsis was considered to be a major motor disorder, while IEM was used synonymously for minor motor disorders. The new iteration of the classification of motor disorders now divides this motility into disorders of esophagogastric junction outflow, as well as into disorders of peristalsis. Within this, absent peristalsis and IEM lie. So I'm going to discuss these concepts. The definition of absent contraction hasn't changed compared to the previous iteration. Absent contraction is defined as 100% failed peristalsis and a normal median IRP, in other words, no obstruction. IEM, ineffective esophageal motility, is defined as either greater than 70% ineffective swallows or over 50% failed swallows, with ineffective swallows defined as peristaltic breaks of over 5 centimeters, weak contraction, whereby the distal contractile integral is greater than 100 millimeters of mercury second centimeters, but under 450, or failed peristalsis, whereby DCI is less than 100. We know from the conventional manometry studies that ineffective esophageal motility is not uncommonly associated with ineffective bolus transport. We also know now with high resolution manometry that the reason for this is that the wider the peristaltic break, the more likely there is ineffective and incomplete bolus transport. But how do we know what's relevant? Here's an example of 5 ml water swallows. In this context, the first 3 swallows failed. And then there is a wide gap in peristalsis during the last 3 swallows of this swallow sequence. But so in fact, this is in keeping with ineffective esophageal motility. However, this is my esophagus, and I have no trouble chowing down on a 32-ounce tomahawk steak without any symptoms. And in fact, the Chicago group have already showed us that minor motor disorders commonly are a good prognostic indicator and are associated with either resolution, spontaneous resolution, or a lack of progression over time. So how do we know where patients have relevant symptoms and relevant findings? We need to avoid overdiagnosis as well as underdiagnosis. Let's start with overdiagnosis. The Chicago classification 3.0 has a statement within it that is still relevant. It states, the clinical significance of minor motility disorders continues to be actively debated. It was the strong feeling of the working group that overly classifying these was counterproductive as it distracted attention from the importance of identifying the major disorders. So how do we determine what is relevant? Eduardo Severino and other colleagues have shown us again and again that that as we go from functional heartburn to endoscopy negative reflux disease to erosive esophagitis and then Barrett's esophagus, the likelihood of ineffective esophageal motility and in turn abnormal bolus transport increases. And we know also with the advent of impedance during high resolution manometry that we can see where incomplete bolus transport can occur. However, this is again with 5 ml of water. And again, it is not emphasizing symptoms and trying to reproduce patients' problems. So we have shown repeatedly that swallowing small volumes of fluid whilst supine or even in the upright position does not represent normal behavior and very rarely reproduces symptoms. And one way to circumvent this is to use what we call is known as provocative testing, whereby we try to reproduce normal eating and drinking behavior. And the provocative tests that I'm going to suggest and mention are as follows. This technical review should be in press, hopefully, by the time this presentation is being played. At present, it's just been accepted. We know from the Chicago classification 4.0 that we can study now patients either starting them in the supine position with 10 water swallows or in the upright position, regardless of which position we start the study, in order to identify the different motility abnormalities. There are provocative tests that can enhance the likelihood of identifying these and induce symptoms. In today's talk, what I'm going to be discussing is IEM and aperistalsis. So I will discuss MRS, which is multiple rapid swallow, single solid swallows, and a meal. Multiple rapid swallows has been shown by Prakash Gawali and the St. Louis group, as well as the other groups around the world, to be very useful in identifying what we know now as peristaltic reserve. When you give small volumes of water in sequence, there is profound deglutative inhibition throughout the esophageal body and lower esophageal sphincter, followed by an augmented peristalsis thereafter. Abnormalities of this will lead to an abnormal incomplete inhibition or failure of augmented contraction after the deglutative response. And in fact, we can use this in order to prognosticate outcome following anti-reflux surgery. And the St. Louis group have shown that an abnormal response was most prevalent in patients with any preoperative or late postoperative dysphagia. So how do we define what is normal and abnormal? One way to do this is by measuring the ratio between MRS and single water swallows of the DCI, the distal contractile integral. Anything greater than 1 is considered normal. Less than 1 is more likely to be associated with dysphagia following anti-reflux surgery. Single solid swallows is another way of testing these patients. Patients are given a small solid, such as bread with butter in it, or a dumpling or a biscuit, and they're asked to swallow. And we know from studies that compared to single water swallows, solid swallows are more likely to enhance contraction, increase contractile vigor, reduce the contractile front velocity, and prolong the duration of swallows, of the swallow velocity. We also know that in patients who have endoscopy negative reflux disease, it is not uncommon to find ineffective esophageal motility with water swallows. But when you give solid swallows, it is not uncommon also for this to correct itself, in which case there is peristaltic reserve. Whilst in erosive reflux disease, this is less likely, as you can see here. So this is peristaltic reserve, and here there is absent peristalsis, which persists with erosive reflux disease. Similarly, with Barrett's esophagus, when compared to endoscopy negative reflux disease, ineffective esophageal motility is not uncommon. However, peristaltic reserve is more likely to occur in patients with endoscopy negative reflux disease compared to patients with a long segment of Barrett's. We can also provide patients a solid meal. We published this study in 2014, looking at 18 patients with reflux symptoms who had a cheese and onion pasty. And we found that only a quarter of patients who had reflux disease had effective esophageal motility, whilst half of the patients subjects who were healthy had an effective peristalsis after swallowing. And we saw that with the controls, ineffective swallows were followed by an effective clearing contraction, whilst in reflux disease, this is less likely. And we can see this when we study healthy subjects. We can see that pharyngeal swallows are not uncommonly followed in sequence by a normal clearing contraction. So sometimes there are 2 or 3 pharyngeal swallows before a clearing contraction occurs. And this is normal. Whilst in someone with severe reflux disease, pharyngeal swallows occur in sequence, but then there's nothing that follows them. And when it does, it is hypotensive or fragmented. And it is at that stage that symptoms occur. This was reconfirmed with a study from the Lancet Gastro in 2017 from Mark Fox's group, which looked at 750 patients presenting to their unit with esophageal symptoms. And they looked at lots of things and compared water swallows with a meal, but regards to this talk in particular, ineffective esophageal motility dropped significantly when compared, when water swallows were compared to a meal. And also aperistalsis, the number of patients with aperistalsis dropped as well, many of which then progressed to having normal swallows. 10 patients with absent peristalsis on water swallows had normal peristaltic activity. What is also important is that symptoms were reproduced where there were major motor disorders. In other words, in patients in whom these changes with ineffective esophageal motility or aperistalsis was not clinically significant, symptoms were not reproduced. Here is a patient from our unit. There's clear evidence of a wide gap, wide break in peristalsis, ineffective esophageal motility, DCI was low. With a solid swallow, with a rice meal, peristalsis recovered. And in fact, the patient had absolutely no symptoms. And this patient did not present with this motility, with dysphagia to begin with. Peristaltic recovery is not uncommon. In fact, here are a series of cases just from the last month from my unit. Peristalsis with 5 ml water swallows, which then recover after a solid meal. All of our patients have solid meals in our unit and also have a cup of water to drink freely. And in all these cases, peristalsis recovered after the esophagus was challenged. And when you go back to my swallow, which showed clear evidence of ineffective esophageal motility with water swallows, when I had a meal, my peristalsis was entirely normal after eating as well as after drinking freely. So at least my esophagus is normal. What about underdiagnosis? Here's an example of a patient with peristalsis, and there is no evidence of obstruction. But when 200 ml of water is drunk freely or a meal is provided, you can clearly see that there is obstruction. And so it is very important that patients with peristalsis with no evidence of obstruction have something else done in order to identify and confirm that there is no underlying achalasia. We looked at this and we published this study in 2019 with Sabine Roman's group, and we identified 29 patients who had achalasia but who had normal IRP on 5 ml of water along with peristalsis, all of which were proven to have obstruction with free drinking, solid swallows, or time-bearing esophagogram. And we found that outcomes were exactly the same after being treated for achalasia compared to those with a raised IRP with 5 ml water swallows as per standard. And this applies not only to patients who have suspicion of achalasia, but also those with esophagogastric junction outflow obstruction. As you can see here, again, these are from our group, ineffective esophageal motility or peristalsis, followed by normal motility, but obstruction at the gastroesophageal junction when solid swallows were provided. So if we go back to this algorithm, which I showed earlier, we can see that if you provide provocative tests, we can identify pathology that is relevant as well as exclude clinically irrelevant disease. And the way to do this is to induce provocative tests or use provocative tests in a certain manner. And we propose that if you start the study in the supine position, you should at least perform 3 multiple rapid swallow studies. If you start the study in the upright position, we should be considering rapid drink challenge followed by solid swallows, either single solid swallows or a meal. Thank you very much.